Hi, everyone. Welcome to tonight's webinar, Michigan Center of Regenerative Medicine. We're really excited to share with you data that we've been collecting over 2 years now.
Yep.
And we've been using a platform called Data Biologics, and with the assistance of our patients willing to fill out surveys, we've really got some exciting news to share with you tonight.
I think, and having a patient registry is an important piece of regenerative medicine. So if you're going to do regenerative medicine correctly, in my opinion, I think it's one of the most important pieces with regards to making sure that you're doing the right thing.
Yeah, the clinically proven regenerative medicine with the numbers to prove it is the title for tonight's talk, because we're in a space right now that there are a lot of different treatments that people classify as being regenerative medicine. There's a lot of different misnomers out there, what a stem cell procedure is, what a PRP procedure is, and what Dr. Santana, myself, Dr. Farhat, we're all working together to try to put real science behind what we're doing. And we'll go into the details of what that means when we get more into tonight. So I guess we'll get started. Yeah. So when we talk about a quality regenerative medicine procedure, what does that mean to you?
So something that's quality would be something that's backed by data and science, something that's done in a very medical way of doing it, and also being able to actually quantify your cells and being able to be performed by qualified physicians, right? So location, being able to put the right stem cells, the right orthobiologic PRP in the right location every time, and also being able to put the dosage of the treatments that we're going to do into specific structures. So that kind of makes the difference as far as outcomes of good outcomes versus not so great outcomes.
Correct. I couldn't agree more. Patient selection, what you're injecting and how you're injecting it, I think makes all the difference in the world. And I guess we'd like to share with you some of our results from this data that we've been collecting now for the past 2 years.
All right.
So we're going to pull a slideshow up. We'll try not to make it too dry and really explain what we're looking at here. But the information is important, and I think worth taking the time to really look at these pictures. So if we go to the first slide here, so here's our title slide. And then next slide is our first slide is really looking at all treatment locations. So one of the things that our registry will do is break out the different locations based on body part, and then we drive it down even further based on diagnosis. For example, if we're treating a knee versus a meniscus tear, we can drive it down. But for tonight's talk, we're going to keep it pretty broad because that helps with our numbers as far as volumes. Because when you're looking at science and trying to make statistically significant conclusions, you need larger numbers of patients. So this is kind of a busy slide, but it just shows you two basic lines. The blue line is for all of clinicians who are using the Data Biologics platform. The orange line is Michigan Center of Regenerative Medicine. And it's for all treatments, all conditions treated. So whether it's a spine, a knee, a hip, all conditions are piled into this data here. And the overall good news from this slide is you can see pain levels going down. So if you're a Michigan Center Regenerative Medicine patient, you're on that orange line. If you're at a regenerative clinic outside of Michigan Center Regenerative Medicine, but a regenerative clinic that is also using the Data Biologics platform and importing data, you're on the blue line, and both lines go down. That's the overall good take-home point from this slide. But then even the better take-home point is that if you're a Michigan Center Regenerative Medicine patient, your pain levels go down even further than most other providers who are doing regenerative medicine. So you can see our patients' pain on average is a little bit higher than everyone else in the country when we start. And then after 12 months, our patients' pain levels are slightly lower than everybody else's in the country. We're getting approximate 50, 50.4% reduction in pain for our patients in all conditions treated, which
after a year.
After 1 year is a really good indication that what we're doing is working for the vast majority of our patients.
And that's a big status that a lot of our patients come here for, is because they're in pain, they suffer through pain every day, and knowing that we have data to show you that we can decrease your pain by 50% in 1 year, that's not just a broad claim. We actually have data to show that it actually does happen.
Yep, and these are all patients. We don't just pick the patients who respond. We're picking the patients who also are including the patients who also don't respond. So while we'd love to claim that every patient is going to get a 50% reduction, in reality, some patients might only get a 10% reduction, but then on the other hand, other patients might get a 90% reduction. Yeah. We certainly have these outliers, which we expect to gain great insight to as well. Why does one person respond so exceptionally well and another person doesn't? As we continue to collect these numbers, we'll get more and more data.
Yeah.
So this next slide is same patient population, all conditions treated, but it's a evaluation of function. So the only functional measurement tool that crosses all different treatment categories is your desired function. So when you ask a patient in a series of questions about their desired function, just the opposite of what you saw with the pain graph, you see both graphs going up. Again, the blue graph being regenerative medicine providers across the country who are using the Data Biologics platform, and the orange line being Michigan Center Regenerative Medicine. The, I guess, take-home point from this slide is you can see that while the desired function, for the most part, starts at the same spot for everyone in the country, if you're a Michigan Center Regenerative Medicine patient, you end up getting a better functional outcome than if you're going to another regenerative medicine clinic in the country. So if we start next, we'll start breaking it down more by specific body parts. And there'll be a theme to these slides that you can see. And I think that's why we want to include all the different body parts. Basically, with every one of these slides and every one of these areas that we treat, you're going to see pain levels going down. You're going to see functional levels going up. So this is for our knee patients. Yep. Again, you can see our knee patients tend to be more severe in their pain levels, also in their severity of disease. And so their pain levels naturally start higher than the average pain patient across the country, and yet our pain patients finish lower. I guess maybe let's take a little minute to talk about that a little bit. Do you have any kind of insight as to why that might be? What are we doing differently here that they're not doing in other?
I think one of the things, I mean, there's a lot more nuances to these graphs, right? So a lot of it has to do with numbers as well. We're comparing our clinic sample to a really wide range of samples too, so that could affect the data as well. But also, I think just looking at internally of what we do, I think one of the biggest advantages that we have is we kind of look at different structures and injuries in a more structural way. And then when we treat areas, we tend to treat multiple areas in one sitting. So just for example, if somebody comes in with a osteoarthritis of the knee, we won't just treat the cartilage and the joint itself. We actually look at other structures too, like the meniscus, all the supporting structures, the quadriceps tendon, the patellar tendon, the medial collateral ligaments, all these other supporting structures involved in that, we tend to treat as well. The other things that we do pretty well here is that we do a more comprehensive treatment where we incorporate things like shockwave and EMTT, which is electromagnetic transduction therapy. And to supplement our regenerative medicine treatments, we use supplements that we found has been helpful in increasing cell counts and also platelet numbers. We've talked about a rehab program that we incorporate during our process, and just really putting the patients alongside this whole total gamut of treatments and making them part of the team. So it's not me telling them what to do, but everyone's kind of involved, getting feedback from them. I think that's one of the things that helps us and help our patients kind of succeed in what we're trying to accomplish.
Yeah, I wish I had an answer I could share with everyone. And there's something about, I think what we're doing here in the way that we evaluate our patients, the way that we inject, and the way that we process samples, the cell counts we're getting. We have some slides later to show that our doses are higher than other clinics on average, and I think that probably has a lot to do with it as well, which really speaks towards our lab, which is managed by Gray Ledge Technologies, who manage various labs across the country, giving us really high quality bone marrow concentrate and platelet-rich plasma samples. So again, sticking with knees, and now we're looking at that functional outcome evaluation with desired functional levels. Again, you can see that those are escalating over time while starting at a lower level of function, ending at a higher level of function, a larger percentage of increase in function in our patients than others around the country. And then specifically, the next slide is the Coos Junior scale, which is a scale for specifically for knee patients. There are these surveys, evaluation tools that have been validated by various methods to be really good evaluations for how effective is a treatment. So the Coos Junior is one of those validated tools. So you can see our patients being more severe in their disease, start at a lower level, and then after treatment with us, end up at quite a higher level with, it looks like a greater than 50%, or excuse me, a 37.3% improvement in their functions. But it's not just knees. There's the other joints that we treat. Shoulders, knees being our most common, shoulders being our second most common. I wanted to include the shoulder slides as well. So this is a slide for patients with shoulder problems, and their pain scores, you can see, are starting at a higher level, ending at a lower level than most across the country, with the dramatic improvement in their pain levels. Same thing with the functional slides, the desired function starting at a lower level, ending at a higher level. And then there's a tool for evaluating shoulders, similar to the Coos Junior for the knee. It's called the Quick Dash. So the Quick Dash measures, you can see, start at a higher level and then end at a lower level. And this is an evaluation for disability. So basically, lower is better. And then finally, I wanted to include some slides on spine. Spine being the most, or the third most common thing that we treat, and possibly the most, I think, telling how well our treatments work. Starting again with the pain slide, you can see the pain levels starting high, and then ending quite a bit lower, with a 68% reduction in pain for our spine patients. And then you can see their functional improvements. And the next slide also showing significant improvements with a 88% reduction or improvement in people's function at 1 year. So I kind of saved the best for last, so to speak, and that our functional improvements and our pain reductions in our spine cases really are, I think, dare I say, as good, if not the best in the country. And I think we have a lot to gain from that.
And I think like the big important thing about that too is not just the improvements, but the sustained improvements over a span of 12 months, right? So if you're going to undergo this big procedure, put this big investment on it, you want to see how much of that improvement is. As you can tell from those graphs, they're still trending upward. So that means that after a year, once we compile more of this data, we may still continue to see that improved, the continued improved upslope of improvements, even moving forward beyond a year.
One of the main common questions we get is how long is this procedure going to last? Yep. We haven't been tracking data. We haven't been following patients long enough in a really controlled or specific manner of tracking them. And I guess what I mean by that is typically from a physician standpoint, if somebody doesn't come back and see you, you just assume they're doing well, right? Because people that are doing well don't make appointments, but people who aren't doing well tend to follow up. This is a more dedicated way of actually tracking not just your failures, but your successes as well, to see how well people are doing it for how long. So this is our 6th year in doing regenerative medicine. Yeah. And
we started tracking
2 years ago. Yeah. But I can tell you of the patients I've treated successfully, so far I've had one spine that's come back for retreatment. So I think and we go to our societies and we talk to our other colleagues, that number of anywhere from 5 to 10 years seems to be a relatively consistent theme of timeline for benefit. There's going to be tons of variables that come into play there. How old you are, how severe is your disease, how much activity are you looking to do, how aggressive are you looking to be with whatever joint or area we're treating, as far as how long will that last, or will it come back? When will it come back? Final two slides we alluded to a little bit earlier in looking at dose and response. So this is a graph based on that Coast Junior scale for patients with knee problems and using platelet-rich plasma, PRP, to treat their knee problems. On the left-hand side of the graph going up is a change in their Coast Junior. So you're looking at functional improvement, essentially. And on the bottom axis of the graph, you see the dose of platelets injected in the billions of platelets. And each one of those dots is a different clinic. So as you can see, all the clinics that are reporting to this registry and the different concentrations that they're able to get their platelets to, it's not a direct linear line. And my estimation of why that is it's because it's not only determined by platelet count and dose, but there's lots of other factors that come into play. How you inject, I think, probably being the second most important factor. But you can see our clinic standing up on the far right hand and upper right hand side of the scale, in that we're getting the greatest functional improvements and we're injecting the highest concentrations. So I do think concentration makes a big difference.
Yep.
And credit our lab for their ability to get us such high concentrations. I think that has a lot to do with the quality of our outcomes. Next slide is a similar slide showing pain reduction as a function of platelet counts and platelet dose. And you can see our clinic on the far right hand there, again at the highest concentrations of platelets with the biggest reductions in pain. So I do think there's a lot to do with platelet count and with concentration as to the keys to our success.
Right.
I do think there's a lot of other factors that play into, and we continue to reinvest in other technologies as they come up that we can help to augment and get even better and better outcomes. And that's the beauty of this dashboard, is it is a living outcome registry. And it constantly, if we were to run these reports 6 months from now, they're going to be different numbers. They're continually updating as more and more patients get uploaded to the registry.
Yeah, so I like the fact that these two slides definitely talks to you about how important the dose response curve is. That it's published that in literature it shows that the higher the dose of your PRP, granted that you know how to quantify your PRP is really important because that would make or break your outcomes. But having a high dose amount of PRP over 4 billion is, from what we see in literature, will lead to a really good outcome afterwards. And we see that here. We see it in our lab, which reflects on our data from Data Biologics.
And gets to, when we encourage people that maybe can't see us to seek regenerative medicine providers closer in your area. But one of the first questions you should ask is, what dose are you injecting me with?
Yep.
I think it's a very fair question. If you're going to be prescribed any medication, you're going to want to know what dose, and whether you're given 10 milligrams, 100 milligrams, or 1,000 milligrams would make a difference in the medication you're given. It stands to reason it makes a difference in your response to a stem cell procedure, a PRP procedure, any regenerative medicine procedure you're given.
Yeah.
You should know the dose that you're being given. And
then on that same response too, when patients tell me that they know of someone if they had PRP before and it didn't work, my first question is how much of PRP were you injected? What is the dose of the PRP or the stem cell were you injected before? And more often than not, patients will say, "Oh, I don't know." And unfortunately, at this day and age, in this stage of regenerative medicine, I don't think that's acceptable at this point. I think you have to be a responsible practitioner doing orthobiologics. You have to know the dose that you're giving your patients.
No, I agree. It's been reiterated over the last 3 years that is an extremely important step in moving this space forward, and the science that's necessary to move this space forward. We have to know the dose that we're administering to our patients. So final slide is really a safety slide. So the 3 things that this registry tracks are functional outcomes, pain outcomes, and adverse outcomes. And we're very happy to report that there have been zero serious adverse outcomes. The patients who report any kind of negative outcome, if you look at the pie graph on the right, it's for the most part, they didn't think it was going to hurt as much as it did. And fortunately, that's a short-term recovery type pain, usually lasts 3 to 5 days, and resolves. And every one of our patients who has had that treated or has had pain after their treatment say it's well worth the benefit that you receive in the long run. And the pain that you experience is way less than pain you'd have post-surgical. So while it's still there, and I think it's important that it's there, it shows that this is a registry that captures all data that's given to it. Those 2 zeros on the screen I think are extremely important, in that there have been no life-threatening or serious adverse outcomes. And there isn't a surgical procedure on the market that can claim that.
Right. I just want to reiterate again for all our patients that's gone through the Michigan Center of Regenerative Medicine, and you've agreed to submit your information on Data Biologics. Again, we thank you very much, because none of this data wouldn't be possible without you. You're helping us. You're helping more patients, because we're now really showing and proving that this is a very effective treatment option. And thanks again for doing that.
Yeah, we couldn't get the data. We wouldn't have the science to back up what we do without your support and your continued responses to those surveys that are being sent to you. So thank you so much. And I think we saved enough time for at least a couple questions. We have a whole host that came through. I apologize if we don't get to your question, but I'd like to read a couple of them, and then we can hopefully answer some of these good questions. So I have one here. Do you know or have data or experience with people in pain, but not necessarily from ortho issues, but a condition like hypermobility of the joint, Ehlers-Danlos syndrome, for example? So you want to take that? Yeah, we both, yes.
So yeah, we do. So we do have patients who have joint hypermobility, Ehlers-Danlos type symptoms. We treat them with prolotherapy, with PRP, and with stem cells. We give them all the options, and then we come to the decision which way to go. So far, it works. You know, it's really nice, especially with things like prolotherapy and PRP and stem cells, when we're treating these loose ligaments, that we're able to kind of see improvements subjectively from our patients. I think the next step, as far as looking at that, is in the ideal world, is if we could do a digital motion X-ray before the procedure and then a digital motion X-ray afterwards. Then that'd be a really cool apples to apples comparison of how symptoms are. But from what we see right now from patients subjectively, we are having a really good response for that.
Follow-up question to that, imaging. One of the questions is, do you only rely on what patients tell you, or is there any data, or is there any imaging results that you'll get afterwards?
So again, it's one of these ideal world scenarios that we like to take. So we have a few, right? So to what Dr. Nabby kind of alluded to earlier, a lot of times when our patients don't come back to see us, we assume that things are doing well. Every once in a while, we have a patient come back after a short amount of time or a year or so, and then we're able to kind of get some data. And then we do some improvements from the one that's really popping in my head is a spine that you did from before, where after, is it a year or a year and a half? I can't remember now, but the MRI, the previous MRI before the treatment shows degeneration of the disc. So on T2 image, where it's very sensitive for hydration of the disc, it's really dark. The procedure was done, and the year after on the follow-up MRI, we saw that some hydration returned back on that disc. Mm-hmm. So which is unheard of in any medical procedure that we do, surgical or otherwise, where you can get hydration back in the disc and you're getting some of that suspension back on there. So that's, I think, really good data from just a recent case that I had recently. Doing the procedure under fluoroscopic guidance, we injected a disc and we injected the bone marrow cells, stem cells into the disc space, and immediately after the subsequent procedures and pictures that we took shows an improvement in that vertical gap from that disc. So that was pretty promising as well.
And we do in-house ultrasounds for soft tissue injections that we do. So a lot of like the rotator cuffs that we'll inject, meniscus tears that we'll inject, those things you can see on ultrasound. And typically another question we have is how often do you follow up with our patients? Well, patients come back in at 3 months, and by then you can see changes. It's not fully healed by then. The full heal time is 6 months to a year. So ideally you would wait a whole year to re-image, but having that 3-month image and the trajectory of how people are improving helps us kind of estimate whether they're going to get a ideal 80-90% improvement, or whether they might need a subsequent procedure or some sort of additional treatments to help boost that response. But even we do see post procedure imaging changes, ultrasound, MRI,
right.
X-ray, not terribly much, I would say, but not as much with X-ray because it's not a soft tissue imaging modality. Ultrasound or MRI is the best.
Yeah, and then I also tell patients, so like even after that 3-month ultrasound evaluation, typically of tendons and ligaments, if we don't see improvements that are drastic, it doesn't mean that it's not going to improve. So a lot of times gross changes don't really happen until maybe 6 months or even 9 months later on. So for me, I think it's more important to have that functional, that subjective improvements with your function rather than just kind of seeing it visually. Having both is definitely what we want to see, but this is not necessarily bad if you don't see one or the other.
Yep. Age. I had a question about 70-plus-year-old patients. Do we see those? Do we see success?
Yeah. What's the oldest patient you treated?
95.
Mine was 89. So it doesn't matter with the way that we process our cells and our ability to be able to quantify our cells. We're still able to get or meet that minimum threshold that we look for to get a good response. So, and I think that's one of the best value one of the many things that we're thankful for Graylage for is allowing us to be able to do that, so that we can go tell a patient that, hey, we have this amount of cells. We know that it's going to be a good outcome. So we'll go ahead and proceed with the procedure.
Yeah. And don't get hung up on chronologic age. The year you're born is not as important as how overall healthy you are. And the cells that we're taking out of you are the most important thing, not how old they are or what year you were born. And then labral tears of the hip. Does PRP work for that?
Labral cells for the hip, yes, among many things.
Yeah.
Actually, they're really good treatment option for that.
Yep. So we've treated quite a few of those. We didn't present our hip data tonight, but that's another. I mean, I just think the data was a little bit ad nauseum as it was, so we didn't include any hip data in there. But we have very good supporting data for our hip patients, in particular labral tears. Treated a very good friend of mine, and he had surgery on his hip labrum. It repaired. It felt good, and then he tore it again a year later. We did PRP, and since then he's been feeling great, playing golf,
nice.
Not having any problems. Results vary between men and women.
Good question. I don't think not. So far, I haven't seen anything. There's no inclination one way or the other. And like Dr. Navity says, right, it's kind of like age. It's at the end of the day, it doesn't matter. Also, when we quantify the cells, as long as we have that right amount, it's going to do well.
Yep. And we did not separate that out in our data. That is one of the fields that you can separate out. One of the demographic fields, as is age, and we did not do that, but those would be good to see. The graphs look the same. You look at the different age brackets, you look at different sexes, those same improvement graphs, those trends don't change. I guess, something we didn't say, and one of the nice powerful things about this dashboard is it is something we can bring up in the console. So you come in and say, okay, well, women or men my age with my severe disease, what are your outcomes? And we can dial that in. We can put that into our registry, and you can see with us in the exam rooms what our outcomes look like for patients who look like you. So it's a very helpful thing in the consult. It helps to help with, whether to select to go forward with this procedure or not. If it's something you think that maybe we want to take a look at with us, we would love to provide you with the consult, share our data with you, and then if it's something that you want to move forward with, offer you a really high quality regenerative medicine procedure.
Yep.
We like to keep them at 30 minutes, and we're right at 30. So if we didn't get to your question, we apologize. Please feel free to reach out to us, Michigan Center of Regenerative Medicine. We're in Rochester, Michigan, 248-216-1008. You can also look at us online, regenerativemedicinemichigan.com, and feel free to send us an email, support@mcfrm.com.
Yep, and we do in-person consults and telemedicine consults. So if you have coming from a faraway distance, if you want to have a consultation with either of us, just to kind of pick our brains or interested about these procedures, we'd be more than happy to help. 248-216-1008. All right.
Appreciate it.
Thank you. Good night.
Thank you. Good night.